Okay. Okay. Welcome everybody. Welcome at the afternoon session, or maybe the very early morning session concerning sciatica, and with Tom Jesson. And we are so glad that Tom is joining us and take us through everything sciatica and everything what's happening around here. Well, I think I would say that you probably are the foremost expert in sciatica, because you are the one who have been reading most of it and actually also been really into conversation with a lot of people. So we were more than pleased to hear your story and to follow your lead in hope you can bring us on. The word is up to you, Tom.
Thanks so much, Joost. Do you want me to share my screen?
Yes, please do.
So I click that button. Bear with me.
In the meantime, for those who haven't known yet, Tom just finished up his book concerning sciatica. So we will definitely hear something, and everybody of you who afterwards want to hear more, you can start reading it so that it's even more. Great, Tom.
All right, let's go. First of all, thank you so much for inviting me, Joost, and thanks for having me, everyone. It's a pleasure. I was a student 3 years ago, I think now. I've been calling myself a new graduate, and I think I have to stop calling myself a new graduate now. So what I tried to do today was to think of kind of what you guys want to hear from me. I was looking at some of the other talks as well, and I noticed they're all pretty conceptual. We don't have many kind of clinical talks today, and I think that's probably good, because I think, you know, especially at a conference, especially if you're a student, you don't want to be weighed down by too much clinical detail. So I didn't want to give you kind of the ins and outs of sciatica. I didn't want to tell you kind of everything about it, everything about the assessment and treatment. It's just too much information for you guys to take on, especially if kind of like when I was at university, there were like really different levels of students. So I was completely new to the world of physiotherapy, new to the world of medicine, new to the world of, you know, sport, biology even. And it took me a long time to get stuff that other people seem to find obvious. Like, I don't know how it is in the Netherlands, but in England, in every physiotherapy class, there's like 2 or 3 people who've already studied sports science, and they seem like kind of geniuses. It's incredible how much they know, but I quickly caught up with them, so that's okay. But anyway, for that reason, I think there's like different people in the audience. I didn't want to kind of give you like all just pure clinical stuff, because it would be too much for some people and too little for others. So like, well, what am I going to talk to these people about then? You know, I don't want to do the other thing, which is kind of just give you advice. I didn't want to sort of sit in my rocking chair with my pipe and tell you all the kind of wonderful bits of wisdom that I've learned over the last 3 years that you're yet to understand. And so what I decided to do was just make it a very personal presentation. I'm going to give you reflections on kind of the journey that I've been through so far with sciatica. And you know, I think if you're anything like me, then hopefully a lot of it will ring true and be interesting. And there'll be stuff to take away from it, I hope. So that's what we're going for. And there's a lot of clinical stuff along the way as well.
Perfect. Looking forward.
So first of all, I just want to say I'm a friend to the Dutch people. I've always been a big supporter of the Dutch. This is me in one of my childhood holidays. So when I was, I don't know how old I am there, but the like kind of first overseas vacations we ever took were all to Holland. So I'm from Newcastle in the north of England, and there's a ferry. I guess there probably still is a ferry that goes from Newcastle to Amsterdam. And every year as a family, for maybe 5 or 6 years in a row growing up, we would go over to Holland, as we called it then, and kind of go camping, caravanning. And that was, so I have some very fond memories of visiting the Netherlands, you know, eating chips with mayonnaise, riding bicycles where you kind of sit right back like it's a Harley Davidson. And when you're that age, that kind of thing is just really fantastically good fun. So yeah, a lot of my formative years spent in the Netherlands. Also some kind of less wholesome experiences. I remember one particular time when we were in Amsterdam as a family, taking kind of a wrong turn down the wrong alley, shall we say. and having a different kind of formative experience. But let's not talk too much about that. I'll tell you a little bit about how I came to talk to you here today. This tweet is from 2018, so I just graduated, and I was asked at work to do some research for a little presentation to the other new graduates about something called radicular pain. And I had no idea what radicular pain was at the time, but it's basically another word for sciatica. And I did a bit of a thread on it on Twitter. So I did my research, went on Twitter because I just wanted some likes and retweets, and I did a thread. And it was pretty popular, as you can see. It didn't, break the internet, but a lot of people were interested in what I was saying. And as a kind of new graduate at the time, that was obviously pretty nice. It was nice that kind of more experienced physios were interested in what I was saying. And that was kind of the beginning of a bit of a feedback loop where I just kept researching this topic. I just kept researching sciatica. And sometimes I said stuff that people weren't interested in, so I stopped saying those things and went on to another aspect of sciatica. For example, I think the next thing that I did was I was asked to write a short article for, just a little magazine, physio magazine here in England, or over in England. I'm in America now, about, radiculopathy, radicular pain, referred pain. Basically sciatica, guys, is all we need to know for now. And that was kind of the next stage. And again, that was got a lot of traction. People were really interested in that. So I kind of realized that I was onto something and people cared about this topic. The next thing I did was I was on a podcast. So they asked me to be on this podcast. I never asked if this picture is supposed to be me. I never asked if it was just like a generic physiotherapist or it's supposed to be me, but they asked me to be on this podcast, and that was pretty popular too. The next thing was, I don't know if you guys know about Physio Network, but they asked me to do a short course for them. This is one of the minor regrets of the whole thing, was that I gave them this photograph. So I took this photograph in my flat at about 11 o'clock at night when I was trying to meet the deadline for the course. And I was trying to look very professional. That's what I was going for, was professional. And I think it came off as very smug. I think I looked very pleased with myself in this photograph. And then they went and called it a masterclass as well. So the whole thing looks like I'm very, very pleased with myself, and they promoted it aggressively on Facebook. So every time I went on Facebook for about 2 months afterwards, I was confronted with this picture of myself. The next thing, I managed to finally back it up with some actual research. So I did a literature review with my friend Niels and one of my mentors, Anina Schmidt. And we got that published a few months ago, which was nice. So it's kind of nice to have a reference under your belt as well. So that's kind of why I'm here. And the last step in it is that I finally published a book, self-published a book. As you can see, I didn't put a great deal of effort into the cover. I promise I put more effort into the contents than the cover. And that was just on Tuesday, my time. On Tuesday, I put out the book. And again, thankfully, it's really nice. People have been buying the book, which kind of is nice to get some money for the work that I put in. So I think today, I hope that's kind of a useful bit of context. I don't know who you guys are. I don't know if you've taken the masterclass, if this is all new to you, that kind of things. But so hopefully that gives you some background. And today, I really want to try and be as open as I can about my journey. I have a natural natural maybe modesty or shyness, where I don't want to kind of act like I'm someone who you should look up to or anything. I'm not making any great waves, but I'm doing something that I find really rewarding and that I enjoy. And I found a little niche in physiotherapy that I really like and gives me a lot of satisfaction. So I'm very open to answering any questions that you have about how I found this little niche and what it's like. And if that helps you to, like, I guess, plan your own career and think about what you might want to do with your own career, then that's fantastic. So let's get on to the content, the actual stuff I want to say to you. As I said, reflections from my sciatica journey. I understand that when you're giving a talk, I don't give talks. I've never, like, this is not a prepared talk. I think this is the first talk I've given in years. But I understand that when you're giving a talk to a foreign country, you have to make lots of obvious references to the culture of that country. So today I'm going to let you guys know that what a talk should be is very poised, very singular, and like about one particular thing, perfectly balanced, like a Vermeer painting. This talk is not going to be like that. It's pretty chaotic, and it's a lot more like a Hieronymus Bosch painting. So there's my kind of two obligatory nods to the Dutch people. That's how this is going to go. So hopefully you'll find stuff in there that you like anyway. This is the first thing, the first kind of reflection on my journey, which is that the old ones are the best. And by that, I mean the old papers. When people tell you to read old papers, when they say go back in the literature, some of the old papers are, you know, some of the most insightful things. I always heard that as like people telling me to eat my vegetables. I thought that doesn't sound like much fun at all. I really want to keep up to date with the current cutting edge research and find out like the brand new thing, the brand new piece of knowledge that didn't exist 3 weeks ago that I can tell my patients to help them with sciatica. As it turns out, everyone's right. The old ones are the best. The old songs are the best. The old papers are the best. I'm going to give you an example of one particular old paper. I say old, it's from 1958. I hope that doesn't offend anyone. That's not that old, really, is it? But I'll give you a bit of context before I tell you about the paper. This is these are two pictures. Sorry if you're squeamish, but you kind of got to get used to this stuff, I think. These are two pictures of someone's lumbar spine. So as you all probably know, the spinal cord ends kind of in your upper lumbar spine. And from then on, it's your cauda equina, which is, of course, one of the most important things to know about as a physio, because that's how people get cauda equina syndrome. And the cauda equina is covered by this thing called the thecal sac. So it's the same stuff that covers the brain, and it comes all the way down and covers the cauda equina. It's like not the toughest stuff in the world, but it's pretty thick, and it does a pretty good job of covering the cauda equina, which is why cauda equina syndrome is so rare. As you can see, if you like kind of trace your eyes down at each spinal level, I'm moving my mouse across the screen. I don't know if everyone can see it. At each spinal level, a nerve root for each side exits the cauda equina, and that's going to go off down your leg, into your bum, down your leg, so that you can feel your leg and so that you can move your leg. Let's have a look at what that looks like without the thecal sac. Everyone's, I think, seen pictures like this. It's a pretty orderly kind of series of nerves that descend down the spinal canal, and as you see, each one at each individual level passes off. When we talk about sciatica, so when we talk about nerve root pain, we're talking about something that's irritating, usually just one of these nerves. So as you can see, let's look at this one. Let's look at this nerve. Doesn't really matter which one it is, but as you can see, it's sitting pretty close to this disc here. So if someone has a disc herniation, which does happen sometimes, someone has a disc herniation, that's going to contact that nerve. Now, as we will see, usually that's not too much of a problem, but sometimes things can become irritated and can become sore. But such a small thing and such a small, tiny part of the body can cause people an immense amount of pain. And as you'll know, if you've seen people with sciatica, the pain goes down the leg. And so people get pain, raging pain down the back of their leg when they have something contacting the root there. And one of the reasons, that's just pictures just to show a bit more context. So if one root comes off, it's going to kind of go all the way down your leg like that. And that's often exactly where people feel the pain. And one of the reasons we know this is, as I say, from this study in 1958 by these two chaps, Smith and Wright. And what Smith and Wright did was one of them was a surgeon, or maybe they both were, but during surgery for disc herniations. So in surgery for disc herniation, they kind of open someone up, make a little incision in the back. Obviously, it's not quite this much, but they get in there and they take out the little disc herniation that's pressing on the nerve. And a lot of the time, not always, a lot of the time that makes people feel better. And one of the experiments that Smith and Wright did, which I can never get out of my head, is during the operation. You can imagine this is not too dissimilar to the view they would have had, although obviously they wouldn't have been able to see all this stuff. During the operation, they took a bit of nylon thread and they tied the nylon thread around one of these nerve roots, just in a loop. They tied a loop around one of the nerve roots. And they took the two ends of the thread and they kind of held it out, and then they sewed up the patient like that. And they left those two ends of the thread just hanging out from the back of the patient. And this is one of the reasons why one of the kind of darker reasons why the old papers are the best, is because they used to get away with this stuff. And no ethics board would allow you to do this now. Although they are actually quite clear in the paper that all the patients were giving informed consent, and actually quite a few of them almost weirdly enjoyed the procedure or found it very interesting. So they left this thread hanging out the back of their patients after they'd operated on them. They gave their patients a couple of days to recover, so for the kind of anesthetic to wear off and the worst of the inflammation to go down. And because they'd selected their patients well, almost all of them felt much better after the operation. So their leg pain, that raging leg pain that people feel, their leg pain had gone. What Smith and Wright did next was they went and pulled on that bit of thread to see what would happen. Let me read you, I promise I'm not going to read too much out today, but I'll read you a little bit of their paper. The patient was turned onto the left side and the nylon thread was exposed and a gentle pull exerted on it. The effect was immediate. The patient jumped and explained that a severe pain shot into the right buttock. It disappeared at once when the nylon was relaxed. At the second attempt, the thread was very slowly drawn upon until the patient could feel pain. This time it was not so intense. The thread could be barely touching the root. Then tension was increased, and as it mounted, severe pain spread from the center of the right buttock, down the center of the back of the right thigh, veered laterally to the region of the hamstrings, skipped the side of the knee, and was felt intensely on the lateral side of the calf. It ended about 3 inches above the ankle. The patient described the pain as having exactly the character as that experienced before the operation, but more severe. It appeared to consist of 2 components, a sharp pain which ran as if along a line down the extremity, and a deep, boring, unpleasant sensation felt vaguely in the muscles. So this is incredible. I mean, it's just like the whole paper is full of these observations of what happens when they gently pulled on the roots. One of the key aspects was that if they were to do the same thing to a neighboring nerve root, so a nerve root that hadn't been irritated by a disc, patients barely felt anything at all. So one of the really interesting insights from that paper is that something happens to the nerve to make it really irritated and pissed off, and that when you pull it with the string, it really still hurts. Whereas nerves that aren't touched by discs are not irritated and pissed off. You can tug on them as much as you like and they don't hurt. It's like if you touch your funny bone, it doesn't really hurt that much. It's not very nice, but it doesn't hurt. So that's kind of just a really interesting paper to me, and I can't encourage you enough to kind of read back through the literature. It's not all just about that they got to do cool stuff because there's no ethics boards in those days. It's about people seem to be a lot more willing to say what they thought. These days, I think people are a little bit worried to write their observations in scientific papers because they feel like everything has to be kind of really rigorously evidence-based. Whereas in those days, people kind of were just a bit like more gung-ho about it, and they would just say what they saw. That's one of my observations anyway. The old papers are the best. What I'll do is I meant to put together like a link for you guys of some of my favorites, and I didn't yet, but I'll try and remember to send one to Joost maybe, and he can, or you guys can email me. I'll put up my contact details at the end. Here's another one of my kind of reflections on my journey. It was really pretty simple in the end, and that's okay. I know Ben Cormack came to talk to you 2 days ago, I think, and I tuned into a bit of his talk. And Ben's fantastic because he makes everything sound so simple. And so does his colleague, Adam. They make everything sound so simple. And I always kind of, I was never quite sure about that because it's so easy to say things are simple when you've got like 20 years or so of experience. And you sit back and say, oh, it's all so simple. But I was never sure about that. And also, I didn't like that it was simple. I didn't want it to be simple. I wanted it to be complicated. It's fun when things are complicated. But I think on my sciatica journey, I got a bit of a taste of what people mean when they say, kind of, it's all pretty simple in the end. But once you've taken like a deep dive into the literature and you've learned a ton of stuff and you've kind of really struggled with things, the simplicity that comes out at the other end is a different kind of simplicity. And I'll try and explain to you guys what I mean. I'll try and put it in concrete terms. I think this is what I thought it was going to be like, is like, you know, when I learned stuff, I would have like this simple idea at the beginning, and then I'd develop like a more complex idea, and it would be kind of like, I'd have such a sophisticated understanding of the world. It is true that it was simple at the beginning and then it got more complicated, but as time goes on, things do just get simple again, as I say, and I'll give you an example of what I mean. At first, when I started researching sciatica, I thought for the longest time that it was just about people getting like a disc herniation, and the disc herniation presses on the nerve. So I thought it was just about this, like what's happening in this picture. It's really simple. People get a disc herniation, it presses on the nerve. Simple as that. Now, because you guys have a wonderful lecturer, I know you guys know it's not that simple. But I kind of learned it eventually. And I went on to this kind of stage two complexity, where I was kind of drawing wild diagrams like this one to try and understand what happens when people have sciatica. And don't worry, I'm not going to take you through it. This is really interesting, it's cool, but it's just at the end of the day, you kind of end up in what I call, I don't know if I've invented this phrase, stage 3 simplicity. And stage 3 simplicity is for me is pretty similar to stage 1, except I made a bit of an adaptation. And I'll try and explain to you like my really simple understanding of what's happening when people have sciatica. This is my attempt at drawing the nerve root, so what we just saw like in the previous point. It's true, a lot of the time the nerve root is crowded out or by a disc. So people get a disc herniation, it causes sciatica. So if you look at that one on the far right, that's kind of a really dramatic example of someone having a disc herniation, and it squashes that root, it pins it, it crushes it. It's horrible to think about. But I think that's actually relatively rare. And there are lots of different degrees of pressure that a herniation can put on a disc. Sometimes it can just, the herniation can put on a root. Sometimes that herniation can just gently press on the root. The root's kind of held in place there, and if something presses on it, it can't really escape. So it doesn't really have to be absolutely crushed to have an injury. You could just have something gently pressing on it, and because it can't escape, it's slowly going to get more irritated. And sometimes the disc herniation doesn't have to touch the root at all. It can just kind of be in the vague area and crowd it out, because there's lots of other stuff around the root. There's loads of fat and ligaments. So if something's kind of squashing it, it's like being on a crowded underground or a crowded kind of subway car. if someone gets in, they don't have to actually touch you to make it more crowded. Because sometimes someone can have a disc herniation and it just kind of crowds out the root, but that's enough to make it really, really hurt. Because I think that's stage 2 of my really very simple understanding of what sciatica is. Not only does something have to press on the root or crowd it out, the root then becomes irritated or pissed off. And I'm not going to go into why, because I don't think we really have to know all the details, but it kind of develops these little hot spots where it's capable of firing its own action potentials from the root. So as we know, where we should get action potentials is from like our fingertips, right? Or from the tips of our toes, you know, from our skin, from our muscles, and they're supposed to fire up from our brain. So if I touch something, a little action potential goes up to my brain. When a nerve root is irritated, pissed off, it can fire those action potentials itself. So even though I'm not touching anything, it can start firing a bunch of shit up to the brain, basically. And that's when people start getting that pain all the way down their leg. So I've kind of ended up back at this really simple understanding of nerve root pain. And I hope that kind of helps a little bit for you, this 2-stage model. The nerve root's a bit pressured, a bit crowded out, but then it starts to get irritated and inflamed and sore. And that's when the trouble happens. All right. This is the third kind of point that I want to make. And maybe we can do this one and the next one, and maybe then take a break, Joost. I don't know what you think, because it's kind of almost in 2 halves. The first half is pretty clinical and the second half is a bit more general.
It would be perfect. Yeah. We follow your lead.
Okay. This is something that I kind of noticed. After I graduated, I didn't have any prior experience. So I went and practiced, and I was seeing people with all these aches and pains for the first time. So it was all kind of new to me. So it took me a while to realize this. I was seeing people with arthritis, and they were going, "Oh God, my knee really hurts. It's horrible." And I was seeing people with sciatica, and they were saying, "Oh, my leg really hurts. It's horrible." And it took me a few months to realize that the people with sciatica often seem to be in much, much more pain than the people with arthritis. And I didn't realize this because I was asking them to tell me their pain on a pain scale. So the people with arthritis were telling us, "What's your pain out of 10?" People with arthritis were saying, "Oh, it's horrible. It's 7 out of 10. 7 out of 10. So yeah, that sounds pretty bad to me. I'd ask people with sciatica, "What's your pain out of 10? And they would say, "It's horrible. It's 9 out of 10. 9 out of 10. And I had this kind of idea of the pain scale in my head as something where everything steps up. So one point on the pain scale is like one little unit of pain. So 9 out of 10 pain is just a couple of units more than 7 out of 10. It's not much. It's worse, but it's not much worse. Now, I absolutely hate to give this man more publicity. He certainly doesn't need it. But this is the only one I could find. The only version I could find of this is from Adam Meekins. He does do some good stuff, to be fair. Let's ask the person with osteoarthritis what their pain is, and they're going to tell us it's 7 out of 10 pain on this scale, where pain is kind of non-linear. Then we ask the person with sciatica what their pain is, and they say 9 out of 10, and it's all the way up here. And the difference is almost double. It's almost an order of magnitude greater than the person with 7 out of 10. And this is kind of, I don't know if this sounds obvious, like I'm saying it, maybe it is obvious. This was kind of a revelation to me that, because I've never had like any serious pain conditions really. So I didn't really appreciate that there were people that I was seeing who had pain that they were telling me was like 2 points more, which doesn't sound much, but it was actually off the charts worse than anything I could even imagine. Something I couldn't appreciate at all until it finally sort of clicked. And I realized that people with sciatica, not all of them, but some of them have pain that is much worse than anything else I was seeing in clinic. So I was kind of working in your average GP practice. Almost everyone I saw had like joint pain, bit of back pain. It's bad, but no one had kind of that true nerve pain, which can be kind of off the scale, off the charts, or we make a new kind of pain scale right there, kind of almost like double. And I don't know how much that means to you guys, like how much clinical experience you have, and maybe you're thinking this all seems very abstract. Maybe even people who do think it sounds abstract, but to me, this is kind of a big realization, and it really affected my practice, because at the moment we're kind of all encouraging people to self-manage their pain. We're giving them kind of mindfulness apps and steering them away from interventions like injections and surgery, which is a trend I broadly support. But when I started to appreciate kind of this thing, then I started to kind of be more in favor of interventions that are not very fashionable at the moment, like medication, surgery, injections, to help people who are suffering desperately. Here's another way of looking at it. I don't know, maybe this is kind of more visually intuitive to you. This is from the Effective Altruism Forum. This is kind of how the pain scale sort of implies that pain feels. So kind of each kind of unit on the pain scale, like 7, 8, 9, you get like a little bit more pain somewhere. This guy has like a few more little areas of fire on his body than this guy. And this is what the kind of non-linear pain scale says, which is that for each one, you're actually going like a huge jump up when you get into 7, 8, 9. So people with this is something interesting people with sciatica say, actually very, very common, is that they say it was worse than childbirth. Women with sciatica say it's one of the only experiences they've had that was worse than childbirth. So this is depressing stuff, isn't it? Let's finish with one more thing. I'll try and keep this one snappy, and then we'll see if Joost wants to take a little break. Expectations are tricky. This is another thing, and it took me a while for like the penny to drop. This is what happens if you kind of Google how long does sciatica last. And this chart is from a big surgeons association, which I won't name and shame. But what this chart basically says is that if you get sciatica, 100% of sciatica people have sciatica at the first week, obviously. After 4 weeks, only 25% of them will still have sciatica. After 8 weeks, only, 15% of people will still have sciatica. And after 12 weeks, only 5% will have sciatica. Fantastic. It's got a favorable natural history, and we can reassure our patients. It's very optimistic, unfortunately, because this is actually what happens when people have sciatica. Each green line is one person's journey, I suppose. As you can see, they definitely don't go in a straight line at all. And the red line is the average of all the lines. And it's not going down nearly as quickly as we would hope. The one really important difference with this chart is that some of these people, when they started measuring, had already had sciatica for a few months. So it's like it's not totally the same thing that it's showing. But the point is that, again, it sounds obvious kind of once you say it, a lot of people who have sciatica or any pain just don't get better. Or they get better and it takes like a year or 2 years. But I was out here for months telling people that, oh, you've got sciatica, that's terrible, but don't worry. It's like 4 to 12 weeks and you'll be fine. You'll be back in the gym. Everything will be great. We don't need to, just don't worry. We don't need to give you any pills. It's fine. It sounds like a small thing, but it's again like, I'll skip that slide because we're running behind. It's like really important, because if you tell people, if you overpromise and tell people that everything's going to get better, then they'll just wait. They'll just wait for it to get better. And this is like a really common thing in people with sciatica, I guess other people as well, but just because I'm so obsessed and focused on it, will say is that they got sciatica, and their doctor said, oh, it's like 4 to 12 weeks. So they just waited and they stopped doing everything. They said, okay, well, I'll not go to the gym. I'll wait like 3 months and I'll go. I'll take some time off work, and I'll not play with the kids until it feels better. And as we've seen, it often just doesn't get better. And people end up in this hole, just kind of waiting. Here's a quote from a study by Saunders et al. It's as if everything stopped on August the 12th when this patient got sciatica. It is as if everything stopped, but I know my health will come back. And this person had sciatica for 1 year. So statistically, they're quite likely to have it for quite a lot longer. So it really matters what we tell people about how long their condition is going to last. Here's a quote from Tina Price, who is a person with sciatica who blogs at livingwellpain.net, which I recommend. She said, I think clinicians should be more honest from the beginning when they know there could be a chance of long-term pain. Mine weren't. And she said, because they didn't talk to her about that, it took her a long time to come to terms with it mentally. It was quite a lot of mental work to do to appreciate that maybe you might be in pain for a long time. So what I've been advocating in these little talks is that when people have sciatica early on, we should gently kind of inform them that a small proportion of people who get sciatica don't get better. And that's a very tricky thing to do, because if you've had like a placement and you've seen people who have pain, the one thing you want to do is give them a lot of hope and have them leaving happy and hopeful, and we should still be aiming for that. But I wanted to make just a small plea for maybe adapting your explanations of what to expect to include the fact that a small proportion of people who get sciatica and any pain condition don't get better. And what I think of that is filling in that hole before they get there. This picture is not a good picture because it looks like he's filling in the hole with the person inside. Don't do that. The point is that you're supposed to fill in the hole before they get there. Maybe I'll find a better one if I ever give this presentation again. I think that's the last thing. Yeah, I think that's the last thing for like the first half, where it's kind of all clinical. Because I'm talking to a webcam, I have no idea how this is going and how people are finding it. So maybe we can take a break, and I'm happy for Joost to ask any questions that he or anyone has, or we can just move on.
Oh, Tom, wonderful. I think it's really intriguing conversation so far. So I just, in between, so I stopped the presentation so that you have so you see directly who are looking on. As you see, you also have one of your friends is looking at you. So there's a lot of people, yeah. So we have a great group here. I think it's quite interesting, especially how you took the message and how the way of looking upon sciatica changed a bit over time, and at the same, it's changed you, and at the same time it didn't change. But it's also this morning we had a conversation on course health, also with Tina Price and with Rani and Raj. Oh, okay. It was really nice in the time you were sleeping, hopefully.
Yeah.
And this comes also kind of we have public health data and we have personalized health data, and that's also what you now talked about with sciatica. If you have this, you can have quite easily a graph and you say, well, most of them go down, but we don't talk about most of them. We talk about the person definitely who is in it, isn't it? That's something which really struck me, especially when with your message on the end. But now, having everybody here, I was just wondering, any one of you thoughts so far? This is the part where the other learners next to me are getting involved. Oh, nice to be so silent. Yeah, that's nice. But now it's time to because I can think of we cross quite a lot of topics so far, and I can think of it that it's hard. Does it fit in with your thoughts about sciatica? referred radiculopathy, or do you have different questions? Jaap, Guusje, Max, mate, David, please.
Hi, Tom.
Hi, David.
This is a funny way of meeting you online. Tom and I were going to talk to each other. I don't think he expected me to talk to him in this format.
So, yeah, David and I, sorry to interrupt the context, David and I have spoken and messaged a lot for 2 or 3 years now. Yep. And I acknowledged his guidance in my book, but I've never spoken to him. Because I don't know, like in person.
I've just picked on you, Tom, in the comment section, because the slide that you put up about Adam is actually my work. If you read underneath the slide, it says pulse, pain skin. But so I picked on you in the comment section. So I have a question for you.
Yeah.
Because Tom's published this fantastic book, which I actually read from cover to cover in about 4.5 hours while I was doing my usual pursuit of spin cycling. So Tom, here's a question. I have this fascination because of my past history with the Mackenzie Institute on this term centralization. So I don't know if you thought about it or considered it when you were talking about in your research about sciatica, but do you have any thoughts on what might cause centralization? I notice you've got a smile coming on your face.
I don't know. So if we put it in a bit of context, so people with sciatica have pain that goes down their leg, or usually like into the calf. And then there's this weird thing where if you ask people with sciatica to repeatedly move their spine in one direction, whether they're kind of going backwards over loads and loads, or whether they're going forwards, that pain will slowly recede. So it slowly kind of creeps up the leg. Not always, I should say, not always by any means, but for some people, it will slowly go up the leg, which is fantastic. That's great. It's one of the few like really satisfying kind of things you can do where people are really happy. I don't have no idea why. I think they call it like a phenomenon because no one really knows why it is. There's a few things. The paper I mentioned before where the two blokes pulled on that nylon thread around that nerve root had the interesting finding that the harder you pull on the thread, the further the pain goes down the leg. So if you just pull the thread very, very gently, then someone will just get pain in the buttock, which is something to remember next time you see someone with just pain in their buttock. And if you pull on the thread harder, then the pain, as you progressively pull harder and harder, the pain will go down their leg, which is astonishing. It's weird. Who knows? So I guess there's an idea that maybe when you kind of do these repeated movements, if you find the right direction, then you're maybe moving something in the spine so that the person has kind of less pressure on the root. But I don't know. I think that sounds very speculative to me. It's a bit of a rubbish answer, but I don't know if you have any ideas yourself, David.
It's a good answer. I'm a bit like a lawyer. Never ask a question you don't know the answer to, or you haven't thought about yourself. So I always use Smith and Wright too, and it's one of my favorite papers. That one of the other things they found was when they pulled on the nylon thread but kept the pressure constant, no matter how long they kept that pressure on, which is another confusing thing, because I know in your book, and we've talked about this, ischemia is one of the bigger causes of sciatica that people don't realize. But as they kept it constant, it stayed in the same place. It didn't get worse. It doesn't migrate down the leg. So this thing of constant pressure does more damage didn't seem to apply when they held the patient's thread steady. It stayed in the same. So if they pulled and it went to the posterior mid-thigh, that's where it would stay, no matter how long they held that constant pressure. And it seems to be proportional. The distance down the leg seems proportional to the amount of pressure, not the duration of pressure. And so it is a confusing thing. And I've asked David Butler and Lorimer Mosley several times, because of this new pain concept that pain's a perception, not something caused by the periphery. what they think about centralization, and nobody seems to have an answer. And everybody always skips over it. Oh, well, it's this, that, and the other. Mm-hmm. But it seems to be a realistically reliable phenomenon that we have no explanation for. The other thing is, Albrecht in Sweden did a study on discs that weren't intact, that had herniated and weren't now reversibly intact. Because the Mackenzie system always suggested it has to be an intact disc mechanism, the disc model. But they did a study and they found patients centralized even on MRI when they didn't have intact discs. So I'm leaning towards that it must have either a nerve root phenomenon. And the other thing is the innervation of the disc. We don't know enough about how that affects when we do movement. So I'm like you, I'm hopeful that the nerve root's the explanation, but I'm not convinced. And it's one of these things that are unexplained. We have this, and it is a pain phenomenon that was, and it's back to these, Robin didn't do any experiments by operating, he did them all by observational studies.
Yeah.
So it's an interesting phenomenon that we seem to have no, but in reverse, we know that peripheralization is true because people's progression of disc herniation generally follows that back, buttock, and then referring down the leg. And sometimes when you extrude, you lose your back pain and have the radicular symptoms raging away without back pain. But it is an interesting phenomenon. I have no explanation either, other than Smith and Wright's paper.
Mm-hmm.
And
I'm glad you don't know either.
Yeah, I don't know. And I've been doing this, like you've been graduated 3 years, I've been graduated 37 years. So good luck.
Can I just say that does, what David says goes back to the thing about the old papers, and which is that Mackenzie thing. If you mention Mackenzie now, is quite can be quite controversial, because in a lot of ways it's the kind of the opposite stuff to evidence-based medicine, and because, as David says, it's all based on observations. And Mackenzie, I haven't read all his books, but I've read some of his stuff, and I've read some people like him, like Syriacs, and these guys are just saying what they saw, and you can't base medicine on that. Like, it's hopeless. Like, it just becomes an old boys club where all these kind of guys sit around in a smoky room and dream up all these fanciful ideas about how the body works and how things work. It's like, I think Trish Greenhall calls it like the old boys club. You can't do that. It's ridiculous. But at the same time, there is just that really boring thing where you can't go too far in the other direction. And I think there's quite unfashionable to talk about Mackenzie now because he was so observational. But at the same time, those powers of observation are what make those old papers so good, and are what make a lot of current papers so bloody boring to read as well, because people are not up for saying what they see, and then maybe they're not looking hard enough.
So I'll praise you about your book. Your book reminded me of the old papers. It's a throwback to it. It's more of a literally journey. That's what I call it, a jaunty journey of your learning experience. And it's an insight into, these guys used to write. Cloward's another example where he did experiments in his garage on cadavers to find out how to do anterior approaches to disc. And then he got his medical students to volunteer and would stick needles in the front of their neck to see where they felt the pain. I mean, these days, you're not going to get away with these studies, but that is another 50s study where we see Cloward spots where disc referral pain to the scapula from the neck. I mean, these were just things that we're not allowed to do anymore. I'm sure you couldn't say to your medical students, lie down and I'll stick a pin through your neck into your disc and we'll see if it hurts.
And, this is very topical, actually, because of the issue of human challenge trials for the COVID vaccine. So when back in March, I volunteered for the human challenge trial, and I really thought that it was going to happen, because it seemed, from my point of view, and this is a huge debate, quite obvious that it should be at least considered that they should allow people like me who are young and healthy to volunteer to get COVID to test the vaccine. But there was absolutely no chance of it. It was never discussed, because getting into funny old territory now, but it seems from a current kind of ethical perspective like you just can't do that. It's a sin of commission to give someone a virus, whereas it's a sin of omission not to do the challenge trial. But
And Rani, who was on earlier from the Cause Health, talked about the thalidomide scare in one of her recent presentations. And the problem with thalidomide, and the problem now we have with the vaccine trials, is they won't and can't test them on pregnant women. But then it opens you up to the discussion of, and we're getting off topic enough, but it opens all these people now don't want to take the vaccine who are pregnant. And so you have this liability issue. And thalidomide is a good example that they never test, even though it was for nausea in pregnancy, it was never tested on pregnant women.
No, I think this is off topic and at the same time it's on topic, because it seems like what you just said, if I just circle it a little bit backwards again, it's in the old books and the old experiments. It's the observation is one thing, but if we go back what you said between the public health and in the personalized data, it's sometimes just the causality that we try to infer out of the observations, which sometimes set us on the wrong foot. So we constantly have to look backwards, what's actually happening under what circumstances. So do we really control the circumstances, or are there other factors involved? So that's interesting to take, for example, dispositionalism or other ways of looking about causality.
Yeah, but I have a saying, none of us necessarily needs what the average of all of us needs.
I think that's a real nice one, David. Mace, you wanted to ask something, or you wanted to add something?
No, I want to ask something while you're saying about the amount of pressure on the central nerve system indicates the placement in the leg body where there is sensitization. Is this an indication of the level of sciatica someone has, or the level of how far along they are? I don't know if it's the right way to say it, but how far you still need to go, or how far you're along with your rehabilitation, or what's your starting point and what you're aiming for? Is it something like you can practically use in a practice with a patient, or is it something that you would, it's just for clinical theoretical part, and practical is just you do it in a whole other way?
That's an interesting question. So first of all, when people get sciatica, as David alluded to, and sorry if you guys have kind of all seen plenty of patients and know this, but very often they get back pain for a little while, and often just a bit of back pain and nothing too serious, and then all of a sudden it kind of explodes into sciatica. So that I'd be interested in hearing David's perspective on this, because I was trying to think of it recently. I think that's the typical way that someone gets sciatica, but David might disagree. I don't think it's often that they will immediately just get raging leg pain. I think usually it kind of grumbles. There's a bit of back pain or a bit of tightness or weirdness in the buttock. Often people will say, I had buttock pain for a while and I didn't know what it was. I thought I had tight glutes. So when it comes on, it seems to start axially, so centrally in the low back and glutes, and then often kind of just all at once, like one thing will happen. And yeah, in my experience too, often it will recede from the periphery proximally. So if someone says, I feel like I have less symptoms in my calf this week, then usually you can say, and this is again going back to the experience and observation thing, because I don't think there's any papers that kind of show this. No. Okay. Usually you can say, yeah, that seems to be that's what happens when people are getting better, so we can feel optimistic about that.
So the way it goes, it starts, is also the way it kind of goes back, or is that too?
Shall I answer?
I
think so. Yeah, I think that's fair to say, David. What do you reckon?
So let's go back to Tom, the original question. If you look back at the older studies, Begg, Falker, Mike George, Boddock, and all these guys. So we're talking about in Tom's. I'll keep pushing Tom's new book, because you all need to buy it. But in the book, Tom talks to this too, and Tom's book basically is about, as a clinician, you should say, that's in that book, which it is. So if you think about it, if we think about somatic pain, which is local structure, that's going to be in the back, a dull ache. So if you get a sprain of a joint, that's generally what happens in your spine. You're basically spraining something. And normally it's going to be something like the disc or the facet or the capsule. That's going to be in your back. But that progresses, and so it becomes somatic referred. So you're going to get dull aching, perhaps from back. It goes back, buttock, and then it may last a bit longer. Then all of a sudden, one day it becomes back, buttock, thigh, and then after that, it's back, buttock, thigh, raging leg pain. These are historically, you can see the progression. You can almost imagine the disc fissuring and cracking and things getting bigger and bigger inside, and it goes further down your leg. One of the nicest studies I read was a study by Popple that explains that progression nicely. It goes back, buttock, thigh, and leg. But then, when this is a good clinical sign, if your back pain stops and you have raging leg pain, it's an absolute sign you've extruded the disc. Because what happens is your movement frees up, but you have raging leg pain and your back pain stops. So that's a good clinical sign to observe. So back to the question is it reliable? Yes. In fact, if you go back to the McKenzie studies, centralization is actually a reliable indicator of a good outcome. And the problem with centralization is it's something we talk about in the clinic. It has to happen in a short period of time, either with a position or a movement. But historically, centralization can occur over time, which is the natural resolution of a condition. So I think the question is this something useful in the clinic? Yes, if you observe it if the patient reports it. I always say this, you don't need to move a patient round to listen for centralization. They can report it in their history. They can say things like, I have leg pain walking around, but when I lie down in bed for maybe 20 minutes, my leg pain will resolve back to my buttock. They are physically describing centralization to you in the role. And that is when you would probably investigate lying down and movements lying down. So you don't need to, I always say that you can't see centralization, you can only hear it. And it's back to this thing, listen to your patient, they will report it. Because we know this, every patient can report peripheralization, i.e. how my patient, but you can also listen to clinically how they centralize, and that's a good indicator that they'll be able to improve.
Yeah, okay, so it's way more important to take the patient's story perspective into account with your
Yeah, and we talked about that this morning. That was the essence of the thing. And I always say, and this is my own thing. I'm going to suggest this to you as students: learn to receive a history, not take one.
Yeah. So instead of just asking specific points in his story, just let him tell everything that he finds necessary for you to know. Yes,
absolutely.
Yes.
Is it also something to do with assumptions you might take of the person's history? What's the question to you, David?
Tell me the question. I'm sorry, Tom.
Oh, yeah.
No,
tell me the question. I missed the question.
Well, you talked about really listening to the patient and hear their story, and has that to do with also assuming how will I say that? Assuming things in their stories to be true, like your own thoughts about what they. I don't know how.
And I understand what you're saying. So let me paraphrase back to you. So one of the hardest journeys of a young clinician is to realize, and Tina Price always talks to this, the patient advocates, that the patient has all the information. They have one witness. We have no witness. So basically, we are like in a courtroom listening to a witness. And the problem is, and studies show this, therapists are prone to interrupting patients to try and find out information. And in fact, they'd be better off listening to patients and not interrupting them, because the information will flow from the patient's story. I always say that the story, the word his, her, their story, not my story, which is a mystery.
Thank you very much. Yeah.
You're welcome. Sorry, Tom.
Oh, Dave, thank you. That was nice.
It's great. I used to, there's a lot of the kind of advice people will give you that it sounds, I must admit, like when people would tell me that stuff when I was a student, listen to the patient's story, they have all the answers. At best, I would think, well, that's obvious. And at worst, I would think that they're just saying that to sound cool or trendy. I thought it was just like something you said, listen to the patient. Because I still think I had that kind of mindset that I was like this detective with all the kind of expertise to, and sometimes it is, very rarely it is like that, but almost all the time it seems true to me. And you don't know it until actually you see it over and over again, that they kind of do have the answers, and you have to kind of do this thing of arriving with the kind of no preconceptions and listen to what they have to say. And it's not just a nice trendy thing to say, it's an absolute core basic truth that makes you a better clinician.
Agree with you. This is quite nice, and it's quite an important factor that we say. It's how we vision ourselves as healthcare professional physiotherapists in this sense. Are we the detectives? Are we going in? Is the patient a passive substitute for our puzzle? Or is it actually the patient who is there, and we are there as a supporting system, as a coach or guidance, or let the story emerge, let their story. It's not about us in this case. So this is also interesting. And at the same time, I guess also in this topic, what we're now talking with sciatica, because there's something which is pain, and is pain a commodity, like we talked yesterday also with Joletta Belton. What is it actually, of how do we perceive it? And at the same time, we have some tissue area, we have some emotional area, we have different aspects. So we circle around it because we probably don't know so much about causation, or we have different philosophical backgrounds. And at the same time, we know so much. So that's always a kind of a barrier what I encounter here. But I think that it was nice to have a little bit of a talk, a discussion in between. And I would say, Tom.
Yeah, so we've been going for an hour now, so I'm absolutely fine. I'm on my second cup of coffee. So like the first one kicked in and this one's going well, but if I won't be offended at all if anyone wants to leave, or like go, if I see you kind of going off and coming back with a drink, that's fine.
Yeah.
But let's crack on. The second half of the presentation, I think,
Please.
is a little bit more, what's it about? It's a little bit more conceptual. I think there's a little bit less clinical stuff, but you'll see. Let's see how it goes. I'll share my screen. All right, so we just filled in the hole with before the patient gets to it. That's the key point there. All right. So again, this is kind of me thinking, well, what have I really been kind of going over my head as I've been on this little journey and trying to catch up with David on his journey. And there's this phrase that kind of keeps sticking in my head, which is reality has a surprising amount of detail. Reality has a surprising amount of detail, and the closer you look, the more stuff you'll find, and it just keeps coming. It's a bit sort of fractal. I don't know, so every kind of door you open, there's like two more doors behind it, and if you go through one of those doors, there's two more behind that. And it's my main point is that it's just like such a fantastic privilege and an honor to be able to like have a job where you get to pay attention to that detail and try to learn about it and try to integrate it into your understanding of the world. Because a lot of people don't have jobs where they get to learn stuff. And so that's been fantastic for me. I want to give you a little example of a cool thing that I learned, which helps me to kind of appreciate how much detail there is to reality. This is a straight leg raise. It's kind of the most basic special test there is. You'll hear a lot of stuff about how special tests are not that special, but I still like this one. I think it's a good test. As you all know, and as we saw earlier, everyone's got a bunch of nerves coming out their back and going down the back of their leg. When people have sciatica, those nerves become very sensitive and it hurts to stretch them. So people with sciatica typically will have a hard time putting their shoes on. They'll have to sit down and kind of bend their knees up. And the straight leg raise is a form of test which just stretches on the nerves that go down the back of your leg. The reason it hurts is because when you stretch the nerves, the nerve roots, which we saw earlier, those things with the nylon threads tied around them, send a bunch of action potentials, a bunch of electrical information up to the brain. It's completely chaotic. It's nothing the brain's ever felt before. You know, it's not moving your leg, it's not walking, it's not kicking a football. It's just this barrage of random electrical information that goes up from the nerve root up to the brain. The brain kind of panics, and that's what causes pain. But another really interesting thing that I learned from reading, again, an old study, actually, I think from the 70s or 80s by Norden. The experimenters did something where they put a little bit of electrical kit that I don't understand on people's legs, on the kind of down around the ankle, to measure what would happen there. And they found that as well, when you stretch someone's sciatic nerve out, as well as sending this kind of barrage of crazy information, crazy electrical impulses up to the brain, you also send one down the leg. This has almost no clinical importance at all. It's almost completely irrelevant as far as I can tell, and it doesn't really mean anything. But it's just one example of how when you kind of keep opening these doors, you find just cool stuff and interesting stuff behind them all the time. And I don't know if, I guess people aren't on clinical placements at the moment, but next time you do a straight leg raise with someone who has sciatica, it might just be interesting to think that you have all these little electrical impulses coming down the nerve, which is completely the wrong direction, and not something that you ever think actually happens, coming down the nerve into your hand, because there's the kind of barrage of electrical impulses go both ways. So just an interesting thing. Reality has a surprising amount of detail, and we're all lucky enough to work in jobs where we can keep discovering these things, which is great. The problem is that reality has a surprising amount of detail, but it's not easy to notice it, in my opinion. Let me tell you about a couple of things that I struggled with. When I first, you saw kind of my journey before, and where I was slowly found myself being someone that other people thought was an expert on sciatica. You have a podcast and stuff, and people would ask me questions. So I would tell people, yes, nerve roots hurt because they're inflamed. And people would say to me, oh, inflammation, what's inflammation? I would say, oh, it's very complicated. It's very complex stuff. Or people, you know, I also say, you know, people would say, why do some people have disc herniations, massive disc herniations, but no pain? Which is something, you know, David and I have just been talking about disc herniations causing pain, but of course, as you guys all know, it's not that simple. And lots of people have disc herniations and no pain. Lots of people have pain and no disc herniation. People would say, Tom, why do people have disc herniations and no pain? Like, how can that be? And I would say, it's very complex stuff. And I realized I kept saying that as my kind of get out of jail free card, because I had no idea what the answer was. But it was my way of kind of avoiding learning about that. And this is maybe a very unique thing. And I don't know, I think lots of people will disagree, but I think whenever you hear someone say it's very complex, just consider that they might not have any idea what the answer is, and they're just trying to evade the question for their own sake. And I had to try to learn that for myself, that I needed to stop just saying things were complex and try to actually understand how they work. Here's another thing I found myself doing to avoid realizing the detail of reality. I was understanding things in metaphors. So I wrote, maybe 4 years ago or something, I wrote a long article about the history of pain science. And I realized kind of while I was doing that and after I was doing that, I was writing about pain, but the only things I understood about pain were metaphors. I thought pain is an alarm system. I had this thing from Mosley and Butler that when pain is what happens when there's like a seesaw and there's more evidence of damage or less evidence of damage. And I had this real sense that I understood pain. I really felt like I understood it, but when I actually stepped back and looked at my understanding, it was all just metaphors and all other people's metaphors, which is absolutely fine. But if you're missing out on a lot of the interesting detail of reality if you just stop at these metaphors. So that was, I don't know how kind of weird and maybe individual this point is, but that was the thing on my journey, is I wanted to stop using the excuse, oh, it's complicated, to myself. And I wanted to stop understanding things in terms of metaphors. Now, as it happens, it is pretty complicated. I don't really understand. Each new kind of door you go behind it, it just gets more complicated. And actually, metaphors are pretty much the only way to understand anything. It's metaphors all the way down. But the point is, I think it's the point I'm trying to express is that do yourself the favor of keep investigating and keep opening those doors and keep trying to go deeper. Because if you're anything like me, and maybe you're not like me and you think this is weird, but if you're anything like me, it's incredibly gratifying. Let me give, here's a quote from a kind of obscure blog. What you must avoid is skipping over the mysterious part. You must linger at the mystery to confront it directly. Let me give you an example of what I mean, so I'm not just talking in abstract concepts. One of the things that I started to notice about sciatica after I've been treating it for a few months, as I said, I started to notice that it seems to be, for many people, much more painful than almost anything else I was seeing. And the other thing I started to notice that it comes with all these weird other symptoms. So we haven't mentioned it yet, but people with sciatica don't just have pain. They have numbness, pins and needles, prickling, feelings of running water, feelings that their feet are cold for no particular reason, feelings that their feet are hot for no particular reason. And it sounds crazy, but it took me a while to notice this because I wasn't listening and I wasn't asking. But when I started to read more about this thing, neuropathic pain, then I started to notice it in the world, if you see what I mean. So I had to kind of read about it in order to finally notice it. I recently wrote a blog post about cold feet and sciatica. So cold feet is a pretty common symptom in sciatica. It's really weird, but a lot of people who have sciatica will wear a woolen sock, like even in the summer, because there's nothing they can do to make their foot warm. It just feels cold all the time. There is some like theories of why it is, but well, I don't think you can ask me at the end if you're really interested. But and the interesting thing is that after people have an operation, the foot warms up again pretty immediately often. So I was talking to a friend of mine recently who's just had a decompression surgery for her sciatica, and her cold foot, which she'd had for months, just felt fine the day after. I recently wrote a blog post about this. Why do people with sciatica have cold feet? It's really weird. And I got a lot of emails back, and some emails were saying, I've always wondered about that. You know, why does everyone have this cold foot? It's so weird. And some emails were saying, I've never noticed that people with sciatica have cold feet. I've been seeing people with sciatica my whole professional life, and I've never noticed it. And I thought that was like an interesting kind of lesson in how much detail there is to the world and how much detail there is to patients' stories and patients' pain, that it's weirdly hard to notice. Once you've noticed it, it seems obvious. But until you do, it's just hiding in plain sight very often. And the problem with that is that once you've noticed stuff, it's very hard to imagine what it's like not to know about it. And so this is called the curse of knowledge. So the thing on the left is fairly self-explanatory. You know, if you know the direction to the pub and someone asks you how to get to the pub, it seems obvious to you as you're telling them the directions, but to them because you know them, but to them it may be completely uninterpretable. Another example of the curse of knowledge, of how when you know something, it's almost impossible to imagine not knowing it, is an interesting experiment where often, I've had this experience, if you have a tune in your head and you tap it out on the table, or often if you even hum it, it will seem so completely obvious to you what you're humming or what you're tapping out, but to the listener, they have no idea what you're doing because they can't hear it in their head. They don't know what you know. That was Happy Birthday, by the way. I don't know if that was obvious to you, but I could hear it in my head, so it was obvious to me. So the point is that reality has a surprising amount of detail, and when you notice it, it's obvious to you. How can someone not know that? How does someone not notice that people with sciatica have cold feet? But that's the curse of knowledge. And let me give you another example with patients. So I'll use, I mentioned Tina, and it sounds like you guys met her earlier, which is fantastic. I was speaking to Tina, and she said that one of the most valuable things that she learned, actually, I can't remember the story properly. I'm really sorry for misrepresenting it. One of the most valuable things that she learned after some not particularly useful physiotherapy for a long time is that she met a physio called Matt, who I think you may also have met actually. And Matt helped her to work out positions that were comfortable to sit in and comfortable to stand in. And also talked to her about, she was using a roll, like a lumbar roll, like the picture on the right. So she was using a roll in her spine, which she thought was a good idea, but it was just making things worse. And she had to try and use a softer one. I hope I've represented that correctly. If I haven't, this is a really common point anyway. I think this is a good example of the curse of knowledge, because as a physiotherapist, I would very often kind of gloss over this stuff as too obvious. As physiotherapists, we think all the time about our bodies. We think about the positions our bodies are in. We know what our muscles are doing when we're in different positions and what our nerves are doing. It's obvious that if you sit in a particular way, you're stretching out your sciatic nerve and so on. We're very kind of bodily aware. Some people just aren't. Most people just don't have, we're kind of weird in that sense. So a good example of the curse of knowledge is that there are very things that you know, like if a lumbar roll isn't helping, stop using it. Or if you sit with your legs stretched out, then it might make your sciatica worse because it stretches that nerve. There are things that you know that seem very obvious to you, so obvious that you might not think it's necessary to even mention them or talk about them, that may not be obvious to patients at all. And again, I don't know if that's a particularly useful point, but it's something that I had to kind of learn the hard way, because I glossed over this stuff for so long because I thought, it seems obvious. I don't want to talk about it, but it's really important. Okay, we have 2 points left. I hope everyone's still with me. We're really getting onto the conceptual stuff now, but I know that that's what Joost loves, is all this. Mappers have more fun than packers. Don't worry, I'll give you some specific examples of what I'm talking about. I think there's 2 kinds of people in the world. When you're reading, you're practicing clinically, you're trying to learn about the world, you're gathering all this knowledge, there's 2 kinds of people. There's mappers. And mappers are people who are actively able to integrate novel or ambiguous information into building new mental frameworks. So if they learn something new, if they learn something that doesn't quite make sense, like centralization, for example, they're kind of agile. They're kind of able to make a new map of the world for what that thing is. They're always kind of taking this new information and they're able to put it in different places. If they don't have anywhere to put the information, they'll make a new map and put it there. always integrating stuff into different maps. And that is really, really fun. It's probably the most fun way to go through the world. Packers are those who take novel or ambiguous information and attempt to categorize it into older frameworks. So packers have a few bags in their head, and when they learn stuff, they try and shove it in that bag even if it doesn't fit. Often they get into trouble because if they find something that they can't fit into one of the categories in their head, they get really upset. They either try and shove it into a bag where it doesn't fit, or they just pretend it's all bullshit, centralization's rubbish, Mackenzie's a load of crap, and they throw it out. Be a mapper, not a packer, it's much more fun. Let me give you some examples of what I mean. Ben Cormack talked about this in his presentation, when people say things work or they don't work. I think that's a feature of packers, people who try and pack everything in. Mackenzie works or Mackenzie doesn't work. There's one particular thing that comes up a lot for sciatica, and that's a medication called gabapentin. So sciatica, as we've seen, is a nerve pain, and has a wide spectrum of symptoms, but people with nerve pain have shooting pain, shocking pain, electric pain, pins and needles, hot legs, cold legs, that sort of thing, crazy stuff. Gabapentin is a medication that you take for nerve pain. Gabapentin's been having a hard time at the moment because evidence keeps coming out that it's not that good. It's good for some particular kinds of nerve pain, it seems, but there's been one or two trials lately that say that gabapentin does not work for sciatica. That's what they say. Here's an example. Don't mind using him. I'm pretty sure he's not watching. A precise trial, says Chris Marr, shows pregabalin. So pregabalin is, let's just say it's gabapentin. It's a bit different, but it's basically the same thing. Pregabalin, ineffective for sciatica. And I chose this tweet because Chris can definitely take it. He won't be hurt at all by me picking on him. But if you kind of search on Twitter, you'll find endlessly people saying that pregabalin and gabapentin don't work for sciatica. They're packing stuff in to the work or the doesn't work category. So how do you deal with, oh, and this is me, I should have said. This is me, this is the presentation I gave when I had worse taste in color schemes. This is maybe 3 or 4 years ago, probably 4 years ago. And here's me talking about gabapentin. Tell patients that gabapentin is there, explain the evidence, it doesn't really work, explain the side effects, offer to write to the GP maybe, but look, they're probably not missing much. People don't need gabapentin. It doesn't work, that's what the trials say. As I've tried to become more of a mapper, I've tried to actually notice information that contradicts that. Here's my mate, Jack, who you may know. Jack had a pretty serious episode of radiculopathy a few years ago. Without cocodamol and pregabalin, again, sorry, gabapentin's pregabalin, same thing-ish. Without cocodamol and pregabalin, I don't think I'd have stayed in work during my most significant sciatica episode. That was while optimizing all the other strategies to the best of my ability. So it worked for him. What do we make of that information? Here's Kate, who I mentioned earlier. I've recorded a couple of podcasts with Kate. She's a physio as well, and she's had a pretty serious episode of sciatica. She says, I had a prolapsed lumbar disc with excruciating sciatica. I used gabapentin, titrating up, and then over 9 months, titrate down. It made a difference to my pain instantly. I was able to restore function and get back to participating in triathlons, lifting weights, and being a physio. 4 years later, so she had 2 episodes. 4 years later, I've done it again. It helped immensely. I am now managing to titrate down slowly. So what do we do with that information? If you're a packer and you think things either work or they don't work, and the evidence will tell you that, you'll say that Kate and Jack merely were benefiting from the placebo effect. And there's an argument to that, but Kate, when we talked about it, gabapentin was the only thing that worked. Nothing else worked. She'd take other pills and she wouldn't get any effect. It was a kind of dose response. So she took more gabapentin, she had more benefit up to a certain point. When she stopped, the pain went away. And there's really clear kind of linear relationship between her getting benefit from gabapentin and taking the gabapentin, which when it happens over enough time, you've got to say, is this really placebo? Is this such a powerful placebo that codeine doesn't work for Kate as a placebo, but gabapentin does? I'm not here to make an argument for gabapentin. I think that's actually a pretty good argument that we shouldn't be prescribing it at all because of all sorts of other reasons. But the point is that when you kind of come up against this information, what I'm trying to do is to try and build new maps of the world, to try and understand why Kate and Jack benefited from gabapentin, but the research evidence says that they didn't. I wrote about that in a newsletter, and I came up with some theories about why gabapentin works, but the evidence says it doesn't. I'm not going to go into it all now. If you email me, happy to send it on. But there's an example again of, mappers, look, it's just way more fun to try and build good maps of the world rather than to try and cram all information into these two binary categories. I'll give one more example of how I've tried to become a mapper and not a packer. I used to have these kind of binaries in my head about typical physio binaries, stuff like biomedicalism versus biopsychosocialism. One's good, one's bad. One of them was structuralism versus pain science. So if you'd asked me kind of a few years ago, I was very much the pain science guy. So everything's kind of all about the brain. The brain feels pain, all that stuff. And I was very easy to critique structuralism. So I use it as like an insult. He's very structuralist. He's a very structuralist physio. He usually doesn't understand the pain science. And what this meant was that at the beginning of the old sciatica journey, I spent years completely ignoring the discs. I spent years just ignoring them because I genuinely thought that they were structuralists. So it was old and out of date, and I didn't need to learn it. I thought it was kind of old stuff. I didn't need to try and integrate it into my map of the world. But as you've just heard me and David talking about, discs are actually pretty important. They're not the be all and end all. There's a load of other causes of sciatica, which I'm conscious we haven't really mentioned them, and we should probably talk about them at some point. But the discs are pretty important, and not only are they important, they're bloody interesting. They're absolutely fascinating things. So I would say maybe something to do, and I hate to give advice because people are generally pretty bad at giving advice, but try and identify these little categories that you have in your head, like structuralism versus pain science. I'm not a structuralist, and see if you're just missing out on stuff because of them. See if you're being too much of a packer and fitting everything into categories. Here's a lovely quote that I put at the beginning of the book from Donella Meadows, who is like a complexity scientist. I don't understand all her science at all, but she seems like a very wise lady. Remember always, she says, that everything you know and everything everyone knows is only a model. Get your model out there where it can be viewed. Invite others to challenge your assumptions and add their own. Instead of becoming a champion for one possible explanation or hypothesis or model, collect as many as possible. Consider all of them to be plausible until you find some evidence that causes you to rule them out. And I think we can replace the word model with map there. Everything you know is only a map. Get your map out there where it can be viewed. Never become a champion for one map, but collect different ones. And again, I'm not saying that because it's like a value. It's just fun. It's just more interesting. This is the last thing, and this is like everything I've said before. Please don't take it as advice, because people advice is only people are terrible at giving advice, and you shouldn't listen to any advice. But this is an absolute straight up piece of advice. Don't wait until you're ready. Get yourself into a positive feedback loop, and I'll explain what I mean. I'm going to show you a Facebook post, which is pretty obscure, but it's always stuck in my head for some reason. I read this a few years ago, 2016 it looks like. Some of you might know Greg Nuckols. If you like going to the gym, you'll know that he's kind of does some fantastic writing about barbell training. He's an incredible writer, and he says, if you wait until you're ready, if you wait until you're good enough, you'll never get anything done. We all have nagging doubts. We all have insecurities. The people who are successful are the people who know how to ignore that voice in the back of their head and get shit done, knowing it'll never be perfect. Now, you might not need to hear that bit of advice, and you might be out there in the world already doing stuff and making mistakes and getting better. But I definitely needed to hear that advice. I was always kind of in the library trying to make everything perfect before I did anything. But one day I just decided to start writing and start putting out blog posts and tweets and stuff like that. And they were not that good at first. Some of them are pretty bad and I'm embarrassed about them. But what I did was I got into this positive feedback loop where I was doing stuff. People were telling me it was good, so I wanted to do more, or they were telling me it was bad, so I could do better next time. A good example of that is I started a newsletter probably just about exactly a year ago now. And this is like a representation. There's not many people subscribing. It's like 1,700. It's not kind of breaking the internet. But this is just like my little corner of my professional life where I get to kind of do things and people keep emailing me, keep telling me, this is great, this is wrong, you've missed this. And to me, that line kind of represents progress that I've made almost. Not many physios like to write. I think I'm maybe quite rare in that respect. But whatever, writing is kind of my thing, but whatever it is for you, I would just recommend, if you need to hear it, get out there and do it. If you're crap at it at first, probably no one's going to notice, so that's fine. And try and find that positive feedback loop, just ride that curve, try and keep doing more and more stuff, making more and more mistakes, and it's just a really fun way to live life. So there's my kind of, I said that at the beginning, I wasn't going to sit back in my armchair and get my pipe out and give you loads of advice about all the amazing bits of wisdom I've learned, but there I had to do it at the end. So what have we learned? The old studies are the best. It's not like eating your vegetables. Go back and read them. It's great. I've learned that it's pretty simple in the end, but you do have to kind of go through the complexity to get to the simplicity. Pain scale is non-linear. There's stuff that you don't appreciate about how serious pain is, or I didn't appreciate. Expectations are tricky. Managing them is tricky. It's not just about reading out a statistic. I learned that the hard way. I learned that reality has a surprising amount of detail. Behind every door, there's more stuff to learn and 2 more doors. I learned that the curse of knowledge is everywhere. If this presentation was crap at any point, it's probably because of the curse of knowledge, and I can't remember what it's like not to know stuff about sciatica, so it's hard for me to explain it now. Mappers have more fun than packers. Keep integrating stuff into your map of the world. Don't just pack stuff into categories. And don't wait until you're ready. Get yourself into a positive feedback loop. Do that now. So those are the reflections from my sciatica journey. As I say, it was pretty messy. It was a lot more Hieronymus Bosch than Vermeer. I'm absolutely happy to take any questions, whether it's clinical, personal, anything you want to know about me. I'm open to that.
Great. First of all, thank you very much, Tom. You really took us on a journey, and as you said, I love the thing about packers and mappers. And to be honest, actually, I would love to see myself as a mapper, but maybe I'm way more a packer in some ways, because I really definitely went those discs out of the window. And now I have to acknowledge again, we have nerves and we have disc, and there's a kind of connection, and at the same time, different things. And I love to do it, but maybe there's more structuralism in me as well. So you really put me in a kind of reflection. That's nice. So I love it. I love it. So are there any questions at the moment from, I will just stop the presentation so that we can see the people around. Does anybody have some question or comments, remarks? Don't be shy. It was so clear. So it seems like, Tom, that it was very clear, actually, what it is. I think in this way it is kind of difficult to look back, and as you say, there's the curse of knowledge that you know so much that it's very hard to understand from what's actually there when we have to go into something as sciatica, radiculopathy, radicular pain, referred pain, centralization, that you have to look upon it from the different angles that you constantly apply to. David.
Yeah, so Tom, you referenced that there were other causes of sciatica other than sort of compressive or restrictive lesions. Could you talk to that point?
So I think one of the things is, as you also said, is the disc. So the disc is a tricky thing, and because it's very unfashionable. So to give guys a bit of history, in 1932, there was a paper published. In the 1920s, no one really knew what was causing sciatica. So people knew that it was, they kind of narrowed it down to the spine. They knew it was something going on in the spine. And but they didn't know what was causing it. And in 1932, a couple of guys in Boston, Massachusetts, I think, they did some research where they worked out that it was the disc. They went back over some biopsies they'd taken from some of their patients, and they worked out that what they thought was cartilage was actually disc material they were finding in these spines. So 1932 is a key year because it kicked off what we now call the dynasty of the disc. Once these guys identified that the disc was causing sciatica, people kind of ran with it and they decided that the disc was causing everything. So over the next few decades, the disc got blamed not only for all cases of sciatica, but all cases of back pain as well, and probably a load of other stuff besides. So people kind of really ran with that. It's not just physios that got it a little bit carried away. It was definitely also doctors and surgeons. And they call that the dynasty of the disc for the rest of the 20th century. And recently there's been a bit of a reaction against that, which is absolutely appropriate. So people have been saying, you know what, we've been obsessed with the disc. We keep cutting out people's discs. It sometimes works, but most of the time it doesn't. We've got to stop doing stuff to people's discs. So there's been a bit of a reaction against that, and it's now maybe a little bit less fashionable to talk about discs. So when I was in uni, we didn't study the disc at all. It was all pain science. And it's definitely, as I say, a good thing that people are getting away from that, because we got far too carried away with that for a few decades. But what I've had to learn personally is that the disc does have a role to play. And, you know, having all been in the Cause Health lecture, I'm sure you will have like sophisticated understandings of how causality works and how the disc is just like one node in that kind of causal network of what causes sciatica. So that's kind of why when you see people like David and I talk about discs, we sometimes kind of trip over our words, because we don't want to imply that the disc is so important, because we've been there and we know that was a huge mistake. But we also don't want to make the other mistake of implying that the disc is irrelevant, because that's going to be a mistake as well. So just to put a bit of context in there, and as I mentioned, there's a ton of other stuff that can cause sciatica as well. One of the other things is, do I have a picture in my, I don't think I have a picture in my presentation, but the nerve root, as you saw it there, is when we look at it on diagrams, you always see kind of the nerve root coming away from the thecal sac and out the foramen, so out the hole in the spine and down the leg. And it looks like it's kind of got loads of space in there. So it looks like the nerve root takes up about a third of the space, and it's got loads of wiggle room in there. Actually, the nerve root is surrounded by fat. So there's fat cushioning the nerve root, and it's surrounded by ligaments. So there's loads of different ligaments in there. So whenever you look at a diagram of the nerve root, just kind of coming out the spine, all comfortable, or you look at like a dissection and someone's taken away all the other stuff and you can just see the nerve root, it's important to kind of mentally put back in there, well, actually it's surrounded by fat, It's surrounded by ligaments. So that means that it's actually pretty, because it doesn't have much room. It's like one person in one subway car. It doesn't have much room to escape or get out of the way when anything increases pressure in that area. So as we get older, we know that you kind of get bony overgrowth in your spine. So just as you get kind of wrinkles or calluses, like I have calluses on my hands, you get calluses in your spine. So you kind of get bony overgrowth in there. Because everything's so packed in there, the nerve root doesn't have kind of anywhere to go. And we call that stenosis. So an already kind of packed space gets even narrower and it kind of crowds out the nerve root. So that's like one other cause of sciatica that doesn't involve what David and I were talking about, which is these big disc herniations that kind of splurge everywhere. That's another kind of reasonably common cause of sciatica. But of course, it's never black and white. So it's really, really common for people's nerve roots to be squashed to like a thread and for them never to feel any pain, because if it happens slowly enough, then the body just adapts and kind of gets used to it. So there's all these other kind of factors that play in. So the nerve is very resilient from one point of view, like you can squash it, you can crush it. If you do it slowly enough, it'll be fine. But at the same time, it is quite vulnerable in that it's already in a tight space. And if you put enough pressure on it for enough time, then it can set off this inflammatory reaction. It can reduce the nerve's blood supply. And we know that if you don't have blood in a part of your body, it hurts, right? That's why exercising is painful for your muscles. It doesn't have enough, you can't get enough blood to supply the demand for oxygen. So as I say, as we get older, bones get a bit bigger, like calluses on your hands, kind of ligaments thicken. Just everything gets a bit more crowded in there. And that can also kind of, given enough time, cause that nerve root to become pissed off and irritated. And then there's kind of more obscure, weird stuff, like people, you know, the shingles, people get herpes zoster virus in their nerve roots. It's an interesting thing to think about. So infections can be a bit of a cause as well. Does that sort of get towards answering your question, David?
Yep, I'm muting myself. Yep, it's and I think that's important to relay to people that when we talk about sciatica, it's just a pattern of pain. It's not, we're not talking to causation, and that's the other thing, that you can have sciatica from multiple other. There's all these discussions. Is it even sciatica can be extra spinal and occur in the buttock area, and that's probably a topic for another day. But and as you know, one of my concerns when we talk about sciatica, we're really talking about nerve roots. And one of the things I tweet a lot. It's one of my obsessions. I tweeted yesterday that we've got to remember that nerve roots and nerve true do not react the same. And that's a bigger topic for discussion. But a nerve doesn't react the same as a nerve root when it's compressed. There's all sorts of different, and I think I emailed Tom the other day about his book and asked him that I'd like to have a discussion with about why the nerve in the cord that's myelinated doesn't react the same as a nerve when it becomes a nerve root. When we talk about upper motor neurons and lower motor neurons, we already know, and this may be something that the students have learned, that there's different reflex changes when we squash the cord versus and why is that? We don't seem to have answers for how the nervous system reacts in different regions to how it's, you know, the same stimulus. Why would pressing on your cord give you a positive Babinski, but pressing on your nerve root doesn't? It's always been something, and why does the cord not heal, but the nerve root does? There are mysteries of life that seem to have no answer. I think it's important to remember that sciatica is multifactorial and a disc is just one causation.
Yes, and I think this is kind of quite interesting. And also, as you said, Dave, there's a lot of topics who kind of connect with each other. And although I think that we can talk for hours more in diving into it, but what I would suggest, having so much, and we dive so much into it, and I see a lot of people also they're topped off almost, and a lot of information and thoughts that are actually the thing I would, if Tom and Dave also like to do it, that we kind of start reflecting on it. We start reading the book, because I think that's I think we need to do some effort. We need to do some effort to understand what's written down there. And I think if it would be possible to connect again in, let's say, a month, and see if we can have a meeting again, and that we have some questions that we can dive a little bit into it based on what is written. If you agree on that one, Tom, Dave, would that be possible?
It's fine by.
Always happy to talk about sciatica. I would say to people, I think there's some links in the YouTube channel is the best way to find it. The article that I wrote, Joost, about for In Touch magazine. Yeah. I think people, I'm doing myself out of, this is not in my best interest to say this, but people should probably read that first. I think it's in the YouTube links. There's an article I wrote for In Touch magazine. It's probably if this is all new to you, that's probably the best place to start. Like, that's free. And if you get on well with that, then maybe think about buying the book. But if that, like, if you, whatever level you're at, that might take like a couple of weeks for you to digest and think about by itself. That might be enough at this point. So don't feel like you have to go and read the whole book quite yet. And the podcast that I did as well, the Physio Matters podcast, talking of the curse of knowledge, I did that a few years ago when I just learned all this stuff and it was fresh in my head. So I was actually much better at explaining what sciatica is back then. So maybe listen to that podcast again, that's free. So read the article, listen to the podcast before you buy the book. They're the best introductions.
That sounds really good. What I would suggest that we dive into the podcast and into the article. Some of us will read the book. Then we will get at least questions, and I think it would be nice to have some questions in advance. So then we can have to introduce you, both you, Tom and David, and to have a conversation concerning the questions and the dilemmas that we actually have, so that we really can show we are mappers and not packers by daring to reach out in our own suggestions and the tensions between them and what can we do about it. So that would be lovely. In this case, on behalf of all of us, I really want to thank you. And can we have a nice applause for Tom right here and having a wonderful conversation. Thank you very much for bringing this onto us and guiding us into the world of sciatica and everything which is even more to explore. As I said earlier today as well, this is not about finding the answer. This is about getting better questions. And I think this is really concerning the questions. Sim. Yes, thank you. Okay, then I will